Great. There we go. All right. Thank you, everybody, for joining us. This is UNC Health and our weekly media briefing. We will get more details for you on our guest speaker today. And please feel free to ask as many questions as you like and follow-ups as well. If you have any problems with your audio, feel free also to send me a chat message, and then I can ask that on your behalf. We will be recording both audio and video, and then immediately after the meeting, we will post these onto a number of areas so you can get immediate access. Hopefully within about 30 minutes, we'll have those files available for you in case you're not able to record. If you do want to record here on your own, you can request that. There's an option to request that, and I'll just need to authorize you. So if you'll do that, that will be great. So we're going to be talking about testing this morning, and we'll be talking with Dr. Melissa Miller, and we'll get a more detailed introduction of her in just a moment. But as many of you probably know, in the very early stages of the pandemic, Dr. Miller and her UNC Health team developed deployable tests for COVID-19 at a time when there were extreme limitations on testing availability. So I will now hand it over to my colleague, Alan Wolf, who will do our introductions, and then we'll get going. Alan?
Thanks, Phil. Thanks for joining us, everyone. Dr. Miller is a professor of pathology and laboratory medicine at the University of North Carolina Chapel Hill School of Medicine. She is also the director of the clinical microbiology and molecular microbiology laboratories for UNC Health. Dr. Miller received her Ph.D. in molecular biology from Princeton and completed the medical and public health microbiology fellowship at UNC. He is also the chair of the American Society for Microbiology Clinical and Public Health Microbiology Committee, a fellow of the American Academy of Microbiology, and an editor for the Journal of Clinical Microbiology. Dr. Miller's research interests include the development of accurate and cost-effective molecular tests for viral infections and the assessment of patient and healthcare outcomes associated with the implementation of new molecular technologies. Dr. Miller, thank you so much for taking the time to join us today. I know your lab is incredibly busy the last few months. Please feel free to make some opening remarks, and then we will open it up to media questions.
Great, that sounds good. Thank you, Phil and Alan, and thank you all for joining me today. There's a little bit of feedback. If everybody could make sure they're muted, we'd appreciate that. So as you all know, you've been covering this. Testing has never been so much in the news, and we're certainly not used to being in the spotlight at any time. And even in the midst of a pandemic, I don't think we really anticipated how much focus and stress there would be surrounding testing issues. You remember from the initial stages of delays with the CDC test, everyone trying to get testing up and going, just like we were here, and then not having enough testing available to even test all symptomatic patients. Well, thankfully, we're through that now. But we continue with supply shortage struggles and being able to have access to all the reagents that we need to do all the testing that we really should be doing in our state and really throughout the country, and the world is having similar issues. So as this pandemic continues to accelerate, again, now testing is kind of at the center of discussion in terms of, is it the source of all the positives that we're seeing? Struggling getting supplies still is an issue. So to give you an example, at UNC Medical Center, we have validated and implemented 4 different tests for detecting the RNA of the SARS-CoV-2 virus. And this is not normal. So most of our infectious disease testing, for a particular virus or bacterium, we have 1 test. At the most, we might have 2 for different reasons. But to have 4 tests to really be doing the same thing tells you kind of the level of capacity that we're building. It also tells you that we needed to diversify in order to keep testing going when there were reagent shortages. So this is something that everyone is struggling with throughout the country. This is not normal. And I think through our societies and other groups that I work with, our hope is that if we learn anything from this pandemic, it will be not to repeat this again, to shape a strategy going forward. So as we have the next outbreak, whether it's as large as this pandemic or not, who knows, those, but we can use what the failures were during this time to inform us going forward. So I'll just leave that as my opening statements, and be happy to hear what's on your mind and what your questions are.
Yes, so for folks in the media, please just jump. We don't have really a good way of doing this other than just having you jump right in. So please, any questions, ask away, and feel free to do follow-ups as well.
Yes, can you hear me?
Yes,
Yes.
yes, we got your Judith.
Hi, this is Judith at CBS 17. Wondering if you could talk more about, you said that there was some supply agent struggles. Can you talk a little bit more about what supplies are most in need right now, you're having trouble finding?
Yeah, it's a little bit of everything, quite honestly. I know that's not a very satisfactory answer, but it's different every week. And I think that's been one of the hardest things is, you know, initially the main crisis, you know, after just getting testing up and going were swabs. Finding enough swabs, finding enough of that transport media that we put the swabs in, and we spent a lot of effort securing different types of swabs and ways to transport these swabs. And I think that effort for us really paid off, and we're in a very good situation in terms of having swabs that will last us months and months of testing at this point. So now we've kind of switched over to the actual testing reagents. And so I mentioned the 4 different tests that we have, and they're from 3 different manufacturers, a little bit more than that because of multiple reagents, but all of them have had shortages. It's really a supply demand problem. There's so much demand for the testing. The biggest issues are with the commercial tests. So we developed our own test, which is, you know, kind of like a recipe that you put together. You get reagents from all different companies and put it together to make a test. That test has been less susceptible to reagent shortages just by the nature of that test. But the commercial products, which really is what allows us to have a very high capacity for testing here at the medical center, we're reliant on getting those tests from that one manufacturer. So if there are either issues with quality control of a particular lot of reagents that doesn't pass, then everyone in the country is going to experience shortages with that. So sometimes it's the testing reagent itself. One of the issues have been like rapid tests. Everybody wants to be able to do a 1-hour test, and that's just not feasible. Sorry, I need to turn my phone off. So we have, sorry about that. So the rapid test has been something of great discussion. A lot of our affiliate labs also use the rapid test, and this has been on allocation for months now. And so every week we find out how much we're getting for that week, and many times it's not enough. So we have backup tests for that. Sometimes it's tips, which is from a third-party reagent, and other plastic consumables like reagent vessels, and other times it's extraction kits, which has been in the news a lot. So this week there's actually 4 different things that are back ordered for 3 different tests that allows us not to be quite at max capacity.
Additional questions from the media, please just go ahead and ask Dr. Miller.
Dr. Miller, it's Rose Hoban from North Carolina Health News.
Hello.
Hi, I am wondering about, you know, we keep hearing about the reagents being a problem. What is the manufacturing process for reagents? Are they, for example, specific to the RNA that you're testing for, and that's why it's difficult to manufacture them? Like, give us a sense as to how these things get backed up.
So I'm certainly not a manufacturing expert. I'll just put that out there. But in general, you know, some of it's just the raw materials that are used. So the rapid tests, for example, they're made of plastic and have to go through a very specific molding process if there are difficulties in getting some of those raw materials. And we've seen this in really bad flu seasons before, for example, but not at this level, because we're not doing this level of testing, even with our really bad flu seasons. So, you know, most companies have a certain number of production lines. They're not only making tests for COVID, they're making tests for lots of other tests, not even just infectious diseases. Some are making tests for cancer and other diagnostic tests. So even though, you know, COVID has been on all of our minds, and we have done a lot of focusing on the testing of COVID, there are still other diseases going on that we need to diagnose and test. So they can't shut down all the manufacturing lines just to produce COVID-based tests. So that balance becomes very difficult then when you have to really ramp up production of one specific line and you only have a certain number of production lines. There's physically only so much you can make in a day, for example. This was an issue with the swabs, for example, early on, an issue now with some of the more rapid tests that we're getting. I do not know what is going on with my phone. I'm so sorry. Let me just silence this real quick. I apologize for that. So it's really, again, just the massive supply demand problem, and that we're asking for so many tests and the manufacturing capability just cannot meet that standard.
This is Judith again at CBS 17. I was reading a little bit about testing sites across the country, you know, not too many, but some having to close because of supply issues. Is that something you foresee happening here in North Carolina at all?
I certainly hope not. I'm in conversation with our state partners as well, and they are getting supplies from federal allocations. FEMA, for example, did supply some swabs and some test kits to the state. And depending on the needs of each entity in the state, we can request help from the state for that. And there's a form online that we can fill out to get more swabs, transport media, even some testing kits. So I do think they've gotten up front of this, and now with the expansion of testing sites and trying to get more testing throughout the state, this has been a very thoughtful process in my opinion. So I do think at some point there may be reagent shortages that impact the number of patients we can actually test. But we're trying to test at max capacity for as long as possible, hoping that some of those issues will be resolved. So far, to my knowledge, there has not been specific UNC sites that have been shut down, like our drive-through clinics and our respiratory diagnostic clinics that we've established due to reagent shortages.
Additional questions from the media, please just ask away.
Hey, this is Elle from 97.9 The Hill. Can you hear me okay?
Yes,
I
Elle, we got
can.
Okay, wonderful. Sorry if this takes a moment to get this full question out, but I was wondering if you can kind of touch on what that max capacity of testing is looking like right now, as well as, you know, I know there's been some rhetoric kind of floating around between different health departments and the CDC about who should be tested, and also, you know, who we have the capacity to test right now. I know some people, maybe just from UNC hospitals alone, have been turned away because they haven't been, you know, showing severe enough symptoms. So to kind of sum it up, I was hoping you could touch on what kind of symptoms you're looking for to test people, and what's the capacity kind of looking like in a little more detail.
So I can talk specifically about laboratory capacity. There's a little bit of feedback. Could everybody please mute? Yeah, thank you. So we have the capacity right now to do about 2,000 tests per day at the medical center. And we support not only the medical center here in Chapel Hill, but also our affiliates throughout the state. And so we're not quite at that capacity right now, but we're testing everything that we're getting in the lab. So to give you an example, yesterday we did about 1,300 tests. This will include both asymptomatic testing, so we test patients upon admission to the hospital, we test patients prior to procedures. It also is symptomatic patients. And as you're probably aware, through the course of the pandemic, even what the CDC has recommended in terms of the symptoms has evolved. And that's just as we've learned more And the symptoms are quite broad and can be very different from patient to patient. So our Respiratory Diagnostic Center here in Chapel Hill both sees asymptomatic patients and symptomatic patients. There's a health screen that you can do online to be seen at these clinics. So where we're going is we're hoping by the middle of August to have about 3,000 tests per day capacity at the medical center. And Rex is working up to having about an additional 1,000 tests per day to help support testing in the Triangle.
I had a question that was sent in on text. Sarah with Cardinal and Pine, and she's asking sort of two questions. One, what's an ideal number of days that should pass before people get the results following a test, and does that compare to how's that compare to what we're seeing? And then there's a second one I can ask after that.
So time to test result is a really important issue. Obviously, you want it as fast as possible. So if we could get accurate results to everyone within an hour, this is the perfect case scenario. That's not reasonable. We don't have enough of accurate, rapid tests to give patients that quick of a response. So we do have certain patients, mostly inpatients and emergency department patients that are being admitted that do get that 1 hour turnaround time. But most patients at our medical center have a turnaround time of less than 24 hours. And the mean turnaround time is about 11 hours for the tests that we're doing. To compare with what some of the reference labs are reporting these days, the turnaround times for many of the reference labs are around 5 days. And this fluctuates a little bit more for them based upon the volume that they're receiving. So one of the reference labs that UNC Healthcare uses, for example, was able to get a 1 to 2 day turnaround time for quite some time. But now that the testing has really increased, it's just a throughput of the instrumentation problem, and the turnaround time is more like 5 days. The challenge when the turnaround time is longer is the contact tracing and being able to get in touch with people who might have been in contact with a positive person. So, you know, the person waiting for their test would have to be quarantined, stay at home until they have the test result. But the delay until they find out they're positive is a delay in contacting people who also need to be tested that might have been in contact with that person. And so that does definitely impact the spread of the disease. So faster is always better.
Quick question here. Could you talk about antibody tests and, you know, what is the use of those? And hang on a second, it moves around. Right now, see, one question said, the FDA has pulled the EUAs for many of those. And what's the status of the specificity and sensitivity? I mean, I guess in general, could you talk about them, and is UNC Health using those?
We do have one serology test that we're offering here at the medical center, and it's done in our immunology department, which I do not oversee, but the directors of that department carefully analyzed multiple antibody tests to pick the one with the highest sensitivity and specificity. So the one that's going to be the most accurate. It's really important, especially in times where we don't know exactly how a test might be used or what it will end up meaning for a patient, that you get as accurate of a test as possible. So that was our goal initially, even though we didn't know how it might be used, is just to get a very accurate test. So on the FDA website, you can actually look, and they have posted real world data of sensitivity, specificity, and even how kind of the accuracy of the test, the predictive value of the test changes with prevalence in the population. So to give you an example, when you have low prevalence, which we, believe it or not, still have in North Carolina, of COVID-19 disease, and particularly measured antibodies, we have about a 2% positivity rate based upon our medical center data. And when you have a low prevalence, that means that a positive is more likely to be a false positive than a true positive. And so we have to take that into account when we have these results. So because of that, antibody tests really haven't been used extensively in terms of diagnosing a patient, even really confirming that you definitely had COVID-19, because we still need to know more about them. However, what has been helpful is to try to figure out kind of what's the epidemiology of COVID-19 in North Carolina. You know, we had no idea, would we be at like a 25% positivity rate like you see in New York and California and other places, or, you know, what was our rate? And what we've seen over the last about month and a half that we've been doing serology testing is the prevalence has changed based upon, does a patient have detectable antibodies, from about 0.8%, now we're up to about 2%. So this probably does really mean that we have more people who have antibodies to COVID-19 in North Carolina, but it's really not used in any diagnostic algorithm at this point.
Additional questions from media. I've got one that got on text, but do we have any live questions? A follow-up from Sarah was, could you also talk about false negatives in commercial tests and how common those might be?
Would this be false negative serology tests or false negative RNA tests?
Ooh, she does not say. Sarah, if you want to elaborate on that, I think.
RNA, okay, I see the chat. Thank you. Yeah, this has been a subject that has really been a little touchy for me, because the early data out of China indicated that the RNA tests missed a third or more of people with COVID-19. These tests and how some of those studies were done were imperfect. You know, we're all doing the best that we can, but those tests weren't as established as the tests that we're using now, haven't been through, for us in the US, an FDA-based process. Even if that's under an emergency use authorization, there's some review of these tests. And so as we have learned more about these tests and we've been able to improve their accuracy, I really believe the false negative rate it's not zero. No test has a false negative rate of 0, but I think it's very small. So to give you an example, I was very interested in this question because I was having to discuss with physicians all the time. You know, they thought their patient had COVID-19, repeated tests were negative. So I went back and I looked at our patients who were symptomatic, had an initial negative test, and then looked to see if they had a subsequent positive test. So that first test would have been a false negative if that is true. And I looked at over 600 patients that met this criteria, and of those patients, there was less than 1% that within 3 days converted from a negative test to a positive test. So that leads me to believe that the RNA tests are very accurate. Of course, it depends on a lot of things, pre-test probability, symptomatic being one of them. Another one is how well the specimen is collected and what specimen type is collected. So it's not as simple to say, you know, false negative rate is 1% or 5%, because there are a lot of nuances in what might lead to that false negative rate. But I firmly do not believe it's nowhere near a quarter or a third of the tests that we're doing.
Sort of a follow-up on antibodies. Oh, hang on, they jumped down. Are the antibody tests sensitive enough to differentiate between COVID-19 or another coronavirus?
Yeah, so that would be its specificity, and that has been some of the issues with some of the COVID-19 serology tests. And one of the important things that we have to determine when we're looking at these tests to implement is how specific they are. So if it's positive, then does that mean that it's positive for SARS-CoV-2 antibodies, or does it mean it could be any potential coronavirus? The one that we use is specific for SARS-CoV-2 antibodies, but there have been some that has showed some cross-reactivity with some other coronaviruses. And that's obviously a big issue, because other coronaviruses are endemic. We see them throughout the year, and it's very common. So we wouldn't want that. To follow up to a question previously that I forgot to comment on was about the FDA revoking the emergency use authorization for some serology tests. You know, and I think that, you know, it's bad that they were available, but in an emergency, I mean, that's exactly what this EUA status is meant for is, these are the data that we have so far. It looks like this test might be helpful based upon the data we have. And as tests get out in the field, if there are problems with them, and you've seen this, there's recently an issue with a manufactured RNA test with false positives. There's been point of care tests. There were issues with false negatives, and now there were issues with the serology tests. And so as we have more data and learn about them, it's appropriate and then they be pulled from the market.
Here's a question that's very specific. Okay, so they're interested in, this comes from Rose Hovan, and she's asking, she's interested in where in a patient's body the virus tends to show up. In other words, can you get a negative result from a nasal swab, but then a positive from a throat swab?
Yeah, so and from respiratory sites, we actually have a lot of data about this, not only at UNC, but just worldwide, what has been published. So what we know is early in the course of symptom onset, the gold standard or the best specimen to collect is a nasopharyngeal swab. So that's that very deep swab that you've seen. So not just shortly in the nose, but all the way back, kind of at the junction of the nasal cavity and the pharynx. So this is not necessarily an easy specimen to collect. You certainly can't self-collect this specimen. So as we've looked at other specimen types, because of swab shortages and even just ease of collection, we're able to see how nasal swabs perform, how throat swabs perform, and even specimens from your lungs. So things you might cough up, or you can do a procedure in the hospital to get saline through your lungs and then test that fluid that comes out. So we've done a number of these studies, and through the course of disease, you tend to see the positives go from the upper respiratory tract to the lower respiratory tract. So you definitely can see further with disease that your nasopharynx or your nasal swab might be negative, but your throat swab or specimens from your lungs might be positive. And we do recommend here at UNC potentially for hospitalized patients who have a negative initial nasopharyngeal swab to collect a lower respiratory tract specimen for diagnosis. So it is important to look at multiple sites. So that's a good question.
Great. Just so we've asked several from chat. Any questions from media on the call, please? We've got a couple more minutes. If you have any questions, please just jump up and ask.
Dr. Miller, could I ask one question? I know you and your team have been going like gangbusters for months now. Can you talk just a little bit about where we go from here? And in a perfect world, are you adding staff? Is it simply just getting the supplies you need to do what needs to be done?
Yes, the staffing issue is an important issue, and yes, we have added staff, and we're actually interviewing to add more staff to be able to increase the testing capacity that we're doing. Also, the medical center has purchased just a different additional equipment. Space is at a premium in the labs and in the medical center in general. So some of these instruments are very large, so finding space for these instruments were a challenge. We're a 24/7 operation. The lab is always a 24/7 operation, but we've had to expand the services that we're offering, for example, late in the evening and overnight, just to get through all of the tests that we're getting. So from multiple angles, and really so our staff at some point can have a vacation and we still are able to maintain capacity. It's been important to build all of these aspects of this. So, we've all said from the beginning, this is a marathon, not a sprint. But I do feel like we've been running the marathon at sprint pace, and we're getting really tired. So I do think, the mental health aspect of this is really important, not just from the frontline responders, but also the people staying at home, the economic impact of this, the businesses, the laboratory is part of that. It's just a never-ending cycle of testing. And so really to be able to relieve some of that mental and emotional angst for our staff in our laboratory has been a central part of what we're trying to achieve here in building capacity.
So we're at 10:30. One last question here that we got via chat. Do you have a sense of how long it typically takes from exposure to the ability to get a positive test on a patient?
So the incubation period can be up to 14 days, but you can have symptoms anywhere from 2 to 5 days all the way up to 14 days. But that is why, the quarantine period, if you've been exposed and you're being tested, is 14 days. It is based upon those data. So when an individual patient might be positive, if they're infected, after a contact, it's very different for different people. So there's not a set number, but it could be up to 14 days.
We do have one more question. This is our bonus question. So what would you say is the biggest lesson learned from your rapid scale up and the rapid adoption of different tests?
That's a great question. The biggest lesson I've learned is that we did not have a plan. And that's not an individual plan for a laboratory. We have done this with the first SARS, we did this with pandemic flu, but it was nothing like this scale. Every laboratory in the country is dealing with the same issues. We're communicating with each other. Our states are trying to help us. States are helping each other, but there's really no national strategy for what we need to do in these situations. A strategy, a plan that can be deployed, that's reproducible from a supply chain perspective. So through some of the societies that I'm involved in, we're trying to establish certain protocols for laboratories, just even helping labs that have never done this type of testing before. So getting testing into rural parts of North Carolina has been really important, and helping them, how do you validate these tests? How many specimens do you do? Even sending them specimens to help validate. So having that established going forward, I think will be very valuable, not only for our own healthcare system, but for other entities in the state and in the country. So the bottom line is, I really hope we use what didn't work during this pandemic. And again, I'm just focused on the testing strategy so that we never have to repeat this again.
Great. Thank you so much, Dr. Miller. We greatly appreciate your time today and explanations for everyone. So just to remind everybody, we will be posting a video and an audio file to both Dropbox and YouTube, so you can get access to those quickly. And if the audio is not gigantic, we should be able to email those for radio stations. I see WCHL typically wants that. So thank you everybody for joining us, and we will make all these files available, and let us know if you have any additional questions. Thank you.